Dr. Kashani, in the world of sleep medicine, one of the conditions that I find incredibly fascinating and is also close to my heart personally is narcolepsy. And one of the reasons I find it so fascinating is because I think it's a very, very misunderstood condition, a lot of misconceptions. People understand things like insomnia. People understand things even like sleep apnea. Everybody's got, a partner who snores all night and understands that. But I think narcolepsy, and especially with what we've seen in media representations and so on, is very, very misunderstood. So I think the first thing I want to do is talk a little bit about understanding narcolepsy. I know it is a relatively rare condition. I mean, I think I was reading that in the US, it's about 200,000 cases. But at the same time, that also begs the question of, is it rare because people don't understand it and it's harder to diagnose and so on. So let's start by explaining a little bit. Let's talk a little bit about what narcolepsy is and what causes it.
Yeah, great question. So narcolepsy, it is actually a sleep disorder of neurologic origin. So it is related to the brain. And essentially, we refer to narcolepsy as a disorder of sleep-wake instability or dysregulation of the sleep-wake system. Without getting too sciencey with it, essentially, one must think of sleep and wake as two states that coexist in a harmony. And there's a certain hormone in our brain that ensures that that harmony is preserved and is stable. Mm-hmm. So essentially, narcolepsy is caused by either a deficiency in this hormone or a dysfunction of this hormone, such that now the hormone that's supposed to be controlling sleep-wake stability and ensuring that sleep and wake are these two states living harmoniously together in an equilibrium state, now that's not there. So essentially you have an unstable sleep-wake system where elements of sleep intrude into the wakeful state. And that's why one of the main symptoms or the cardinal feature of narcolepsy is in fact daytime sleepiness or constant sleepiness regardless of sleep duration. And the same way that wakeful elements sleep elements intrude into wakefulness, elements of wakefulness intrude into sleep as well, such that even though, contrary to popular belief, people who have narcolepsy, a lot of people think that they must sleep great at night just because they're so sleepy all the time that they probably are rescued the moment they get into bed. But in fact, their sleep is just as broken as their wakefulness. So you end up in this sort of 24-hour perpetual cycle of dysfunction between the sleep and wake states.
And if I'm understanding correctly, I mean, one of the major things is entering REM sleep too soon, which can create its own set of issues and a whole lot of other things like you were talking about that have to do with the sleep portion. People will be like, oh my gosh, you're so lucky. You can fall asleep anywhere, anytime. It's like, no, it is not that simple and not that clear and not that nice at all. So can we talk a little bit about some of those issues?
Absolutely. Very well said. Well, as you mentioned, REM sleep or rapid eye movement sleep is that very deep and unique stage of human sleep where we do our dreaming. It's also a stage of sleep in which the brain does a lot of its physiologic recovery, so to speak. In narcolepsy, that stage of sleep in particular is considered particularly, or the instability specifically of the sleep in narcolepsy heavily rests on the instability of rapid eye movement sleep, such that elements that are unique to rapid eye movement sleep, like dreams or vivid images, or the muscle paralysis that we experience when we're in rapid eye movement sleep, which is what prevents us from acting our dreams out
which
physically.
Is essential. People don't realize that that's what's actually going on, and we need that to stay put.
Absolutely. I mean, imagine what would happen if every single night when we had dreams and nightmares, our muscles wouldn't be paralyzed. We would be injuring ourselves and our bed partners nightly, which actually is something that is not uncommon in some people with narcolepsy. That paralysis mechanism that should be occurring sometimes is absent in this condition, not always. But back to your question, a lot of those elements, the muscle paralysis, the vivid images of dreams, instead of being contained within the stage of REM sleep, these elements also start to spill outside of REM sleep and even outside of sleep, such that a lot of people with narcolepsy, in the moments that they're just falling asleep in the beginning of the night when they're still awake, very often they'll have hallucinations or vivid images. They could be auditory hallucinations, they could be sensory hallucinations, where right in those twilight moments that the person's falling asleep, they feel like there's a demon or a presence in the room. These are actually elements of deep rapid eye movement sleep, except that they're not staying put in REM sleep. They're starting to occur right before the person falls asleep.
Seeping out into other
Seeping out into the edges of sleep, correct. Same thing with upon wakening in the morning. Very often people with narcolepsy, as they're just coming out of sleep, they'll also have paralysis, that sleep paralysis feeling that is very transient and feels like you can't move, can be very scary.
Which is exactly very scary, and I mean, it can create, I would imagine, a certain phobia, even of like I'm afraid to fall asleep because I may experience that. Yeah.
You said it perfectly. A lot of people who have narcolepsy actually find that the hallucinations and the paralysis episodes are very distressing, especially because for many of them they occur almost nightly or every single day. So these are some of the kind of secondary features in addition to that core feature of hypersomnolence or excessive sleepiness. But many people with narcolepsy, they do identify these other features. Many people with narcolepsy don't necessarily identify them because these are all very subjective things. They're occurring in moments where our brain is in and out of sleep, so we may not necessarily recall all these phenomena. But what you can always recall is feeling sleepy all the time, and that's the main problem.
And you and I have talked about this previously, and feeling sleepy all the time can have other effects. Besides affecting your work and your life, your quality of life, and so on, it can also affect depression. It can lead to depression, or as you've said, like, is it actually leading to depression, or is it a misdiagnosis of depression? I mean, it's so difficult to pinpoint, I think.
100%. You sound like a sleep doctor right now. This is the conundrum. This is exactly the conundrum that we face every single day in evaluating a lot of these patients, just because before they can see me as a specialist who can test them and get them on the right treatment, they're seeing their primary doctors or they're seeing other doctors, because who do you see when you're feeling tired all the time?
You see your doctor.
You see your doctor, right?
Yeah.
You go to your doctor and tell them, I don't know why I just feel tired all the time. I'm always sleepy, no matter how much I sleep at night. I could sleep more. Sometimes I can sleep 15 hours, so on and so forth. So what happens is you're hearing, and by the way, narcolepsy often develops in the teen years or in the 20s. People are not born with narcolepsy typically, which we can talk about the cause a little bit later. But essentially what happens is you have this teenager who starts to get sleepy out of nowhere. Now they're starting to have problems in school. Now they can't finish their homework. Now they're suffering in school and their grades are suffering. And on top of that, socially speaking, for a teenager to be experiencing something like this in the setting of trying to figure out who they are as a young adult or a teenager can be really difficult and traumatizing in a lot of ways for these people. So you have, once again, this young person who's isolated, sad, doesn't have enough energy to do all the things that they want to do.
Should be doing at that age.
And on top of that, they're performing poorly at school. And then they get taken to a doctor. And now the doctor puts all these pieces together and says, oh, you must be depressed.
Exactly.
You probably have depression.
And sleepiness is a symptom of depression, or can be a symptom of depression anyway.
Well said, absolutely.
So it's completely cyclical now. It's a chicken or an egg situation.
100%, and it can be really hard to tease those two apart, especially because, like you said, depression by itself is one of the most common causes of fatigue and sleepiness in the world, much more common than narcolepsy or any sleep disorder for that matter. So this is something that happens, unfortunately, far too commonly. In fact, data shows that the interval of time in between the onset of symptoms until the correct diagnosis can be up to 12 years in many, many people.
Wow.
And we see these people every single day, and I can't tell you how many antidepressants they've been put on.
I was going to say, you must just get people coming into your office like, I'm on an SSRI, I'm on this, I'm on that, and they're just completely, that's not the solution at all.
Correct. And what's interesting is, not funny, but interesting is that because of what you said, being young and feeling this way out of nowhere and having it impact your daily life and your social life so significantly, that is depressing.
Yeah.
So it's almost inevitable to develop a little component of depressed mood. So naturally, if you're going to give somebody who has a component of depressed mood for any reason an antidepressant, that's probably going to make them feel better. It's just not going to address the sleepiness.
Exactly. So you're dealing with a symptom of it, but not getting to the root cause of what's creating it, which would be much better to treat. Yeah, I mean, honestly, that statistic is a little frightening when you think about the fact that it can take up to 12 years, you know. And especially with, as we were saying, the misconceptions, very few people in their normal life are going to think, maybe I'm narcoleptic. We see images in the media. We see, very exaggerated, very almost quite often comical, representations of what narcolepsy is like. Like, you and I are talking, having a conversation, and I fall asleep. And that's, I think, quite rare. It doesn't happen to a lot of people. So that's a real issue. One thing I wanted to ask you about, because we touched on it a little bit, is let's talk a little bit about the causes. For a lot of people, we understand things like, okay, the cause of X, Y, and Z is genetics. It's hereditary, or lifestyle, or, whatever, trauma in childhood. There are clear kind of causes and onsets for a lot of conditions that we talk about. Does narcolepsy have anything like that? Or is it just, it's just comes out of nowhere,
It's a
essentially?
great question. It's a really good question. At this time, the most popular hypothesis is that narcolepsy is caused by an autoimmune attack. And very often this autoimmune process is triggered by a viral infection or some kind of a illness or sickness.
Really?
For example, in 2008-ish, 2009-ish, when we had that big swine flu epidemic that was affecting a lot of the Western Hemisphere, a lot of people developed narcolepsy after contracting that particular influenza illness.
Statistics actually showed an uptick in diagnosis of narcolepsy?
Absolutely.
Wow.
And that's, we're even starting to see some COVID people turn narcolepsy after a COVID infection.
I was just going to ask about that. I was going to ask, well, if that happened with swine flu, given the scope of COVID and how it has affected people in so many different ways, is that the logical, trajectory that we're going to see? So
absolutely, we're starting to see it. So essentially what's happening is, and this is how a lot of autoimmune disorders develop, but the idea is that the infection kind of reorganizes the immune system or confuses the immune system, for lack of a better word. And what ends up happening is some of our defender cells, what are called our T cells, are immune cells that help kill foreigners or foreign agents and sources of infection. What happens is they end up turning on our body on one very specific part of the brain. It's called the lateral hypothalamus, and that is where hypocretin, the hormone that is deficient in narcolepsy, is produced. And they've also went back and looked at these people's brains on autopsy and confirmed that everything about the brain was completely normal in these people. It was just the production of that one hormone that was affected by this autoimmune attack caused by the viral infection.
And is there a reason why, people who have autoimmune disorders get affected in a variety of ways. It can target their digestive system, their, a lot of different ways. Is there a reason why it would attack that particular aspect or that particular part of the brain and affect the hypocretin versus anything else?
It's the $1 million question.
Okay, well,
the question we're all looking for, but we're all hoping
which then we're going to get to, is just the logical progression from there is there enough research being done to try and get to the bottom of this? But before we talk about that, I still want to talk a little bit about, we talked about it being relatively rare in the US, at least. 200,000 cases, when you think about it, is not a lot, which then begs the question, is it really that rare, or is it underdiagnosed? Is it underdiagnosed because the symptoms are not so easy? It's so easy to diagnose conditions like diabetes, heart condition. They manifest themselves so clearly, but with something as kind of nebulous as this, and also as connected to other things, is it really just not being diagnosed enough?
Definitely.
Okay.
Yes. No, if we want to say relative is a relative term, right? And we can call it a relatively rare disorder. However, it's not nearly as rare as we think. Its prevalence is very much underestimated in all of the data, just because of what you said. When the most prominent feature of a condition is something as subjective as sleepiness, something that every brain and body perceives and feels differently, well, it's no wonder there's so many people with narcolepsy walking around that will never know it, because they've already figured out how much coffee they need to get through their day. They've already figured out when to take their naps in the afternoon to be able to get through the rest of the second part of their day. They already know the minimum duration that they need of their nocturnal sleep in order to ensure that they're okay during the day. People adapt to feeling a certain way, right? We adapt to what becomes, or what is our norm.
Our normal, exactly.
Yeah. So we may not necessarily perceive a problem at all, especially if we can have these other measures to sort of counter those feelings. So this is why it's so underdiagnosed. And I can't tell you how many people with narcolepsy will look me in the eye and say, no, I don't feel sleepy. I just feel tired. I gave up on trying to figure out what the meanings between these different words are, just because, once again, every brain and body perceives these things differently.
Yeah.
So imagine all of those people who say, I'm not sleepy, I'm just tired, and then I test them and they have narcolepsy. Lord knows how much narcolepsy is out there.
Yeah. The other question that I often think about, and this is something that's discussed a lot in medicine, is the discrepancies, socioeconomic status, in different ethnic groups and different cultural groups and different underrepresented minorities or underrepresented communities, minority communities. Are they being diagnosed enough and treated enough? So if we're talking about a condition that is already underdiagnosed, it then makes me wonder, is that even more so for underrepresented communities, for minority communities, because it's almost like, do you even have the luxury of allowing yourself to complain about being sleepy or complain about being tired, or going down the path of seeing your primary and then testing. I mean, and testing for narcolepsy is quite complicated. It's not, I mean, it's not a blood test. It's a whole sleep study. It's overnight. And so that makes me wonder if it's even worse. It's even worse in minority communities and lower socioeconomic communities and so on.
Absolutely, 100%. I mean, there's so much to unpack in what you just said, because it's so true that, like many other conditions and many other disorders within medicine, that there's a socioeconomic component such that certain communities and certain ethnicities are affected much more than others. But with that said, I will say one big reason for this is the fact that, as exactly like what you just said, in terms of getting a proper sleep medicine evaluation by a sleep specialist like myself, and then undergoing the correct diagnostic sleep testing in order to get the diagnosis of narcolepsy.
Mm-hmm.
I mean, there are plenty of cities and states all throughout this country that there is no sleep center. You're talking about rural areas.
That's a very basic, yeah.
Right? It's a very hyper-specialized niche within medicine that we do as sleep specialists, and we're not exactly in every single, podunk town from here all the way to Mississippi. Sometimes you have to go to your nearest academic center where they have a proper sleep center where you can do sleep studies. And now this is obviously a separate issue in the fact that access to sleep medicine and sleep resources is limited comparatively to other specialties.
Mm-hmm.
But it is a big problem because there's so many people out there suffering from sleep disorders, narcolepsy just being one of them, and even getting a proper evaluation and diagnostic test and a proper diagnosis may not be something that's even within your reach.
Yeah. And then just to add to that, treatment options for narcolepsy. The most basic ones are stimulants. We know that let's just give you a stimulant, let's a modafinil or so on. But those don't work for everyone. And then the more advanced and the newer medications for narcolepsy are extremely expensive. I mean, and a lot of insurance companies are not going to cover that. So, I mean, that's just an added layer of difficulty really treating something. Stimulants can be very challenging for a lot of people. So
Absolutely. And you bring up such a good point. And this is an area where, in terms of clinical research, this is definitely one of the areas with a lot of gaping deficiencies, just because at this time, really, like you said, prior to the last 5 or 6 years, the medications and options that we had to prescribe to patients with narcolepsy were really limited to stimulants and one other medication that's a non-stimulant medication called oxybate. Now, over the last 5 years, a few more options have come in, and even novel medications with totally different new type of mechanisms. So that's great that at least there's some research being placed on potential treatments such that now we're getting these new treatments approved and there's studying some new ones underway. But ultimately, our options are relatively limited in treating these people. And in order to treat all of the symptoms of narcolepsy, because like we said, sleepiness is the main one, and it's definitely the most problematic symptom. But many people are distressed by going to sleep at night and having hallucinations. Many people are distressed by having those paralysis episodes. And stimulants don't treat any of those things. So it really just depends on sort of the picture and the situation. But our options are limited, but we're working on it.
Which, I mean, you brought up a very important point. For anything, for treatment, for anything to improve, research has to be done, clinical research, clinical trials, and so on. So let's talk a little bit about what has been done and what is currently being done. I mean, you talked about kind of an uptick in the past 5 or 6 years. So clearly more research has been done. But like we said in the beginning, it still seems like there's not enough.
Most certainly not enough. Thankfully, the FDA has kind of joined the table now, and they're looking more closely at some of these studies that are being conducted by pharmaceutical companies, which obviously that has its own issues as well. It's not the same as an academic university study, but still, if you have high quality data demonstrating that something can be beneficial to a large population, and now you have the FDA on your side to start kind of green lighting and approving these options, then this is absolutely a step in the right direction for us, which we didn't have this kind of progress and data coming out at least 10 or 15 years ago. So with that said, I would just say that it's going to take a lot more time before really these major organizations and support really for research can really be effective enough to really make a change. Because at this time, our NIH doesn't even have a sleep division. The CDC, for example, they have a sleep division that really just deals with sleep disorders and kind of prevalence of sleep disorders and all the public health implications associated with sleep disorders. And that's awesome.
Mm.
Why doesn't the NIH, why doesn't our NIH have that, right?
Mm.
And that's something, in fact, that there's a large number of advocates in the sleep community and nonprofit organizations who are currently actively, as we speak, trying to sort of campaign, and they've even gone to Washington, D.C. and gone to the White House to see what we can do to increase the overall awareness of sleep disorders like narcolepsy, educating people more, clinicians, not just people themselves, but just people to look out for these things and to really take it seriously when you have somebody who says, I'm sleepy no matter what. I'm having a hard time driving. I'm having a hard time working. I'm having a hard time going to school. So I think a lot of it starts with just education and the lack thereof, unfortunately, but hopefully we're moving in the right direction in that way too.
In terms of creating awareness and so on, what are some of the organizations that you're talking about? I believe you mentioned before the Sleep Project is one organization.
Yeah, Project Sleep.
Oh, Project Sleep. I'm sorry, and they are very mindful of some of the things that we talked about in terms of underrepresented communities and creating awareness there, because once again it goes back to even knowing what narcolepsy is or even having heard of it. Is probably much more of a challenge in those communities, let alone diagnosing it, but even just having heard of it. So what are some of the things that are being done to be able to get more people aware, especially in those communities?
Yeah, great question. So Project Sleep that's my favorite nonprofit organization, just because they do really, really wonderful work for narcolepsy, for sleep apnea, really for all sleep disorders and just improving awareness. And they're very, very active in the international community, actually. But there's plenty of these foundations. There's the Hypersomnia Foundation. There's also called Wake Up Narcolepsy. And then there's another one called No Narcolepsy. So all of these programs are great in terms of improving awareness and especially to sort of addressing the equity issue that you were just asking me about. Really, apart from educational materials, fundraisers, events, these are the kind of things that these groups are doing. For example, I'm the president of the California Sleep Society. We have our annual conference. We're a large professional sleep organization here in California. We have a large conference every year, and what we've been doing more recently, which we never did before, was we've started to invite a lot of these patient advocacy groups and nonprofit organizations to come and speak and speak on behalf of the patient experience, because unless you really hear and talk to people who experience these things, regardless of what community they're in, the awareness is going to remain low. Whereas, in our conferences where we always have doctors coming up and sounding off like experts and talking about all of these people, how about let's listen to the people themselves and see what they have to say.
Right.
So I think patient advocacy and people who are actually dealing with these sleep disorders, coming out and really kind of talking about these things and being active in the community and creating this awareness, sponsoring events, fundraisers, coming to these major sleep conferences like ours and others. I think this is the beginning of really improving the education on a community level, at least.
Yeah, I mean, I think I was going to kind of follow up on that and talk about how to engage communities, maybe rural communities, maybe different communities that have less awareness and less involvement. And I think what you're talking about is ways of making them kind of stakeholders, getting them involved in the awareness portion, and then subsequently that'll then get them involved in the research portion and the trials portion, and then in turn the solutions to finding solutions and being part of the treatment. So just kind of, if you could talk about that a little bit, or what are your thoughts on how more can be done in that area?
Yeah, definitely. I actually have a friend who has narcolepsy, and she's also a part of one of these organizations. And one really cool thing that they do is every time clinical trials are happening, or every time there's any kind of clinical research focusing on potential therapies and treatments for narcolepsy, they do a really good job of making sure they blow it up all over these websites, all over their Instagrams, all over different social media outlets to let people know, like, hey guys, I have narcolepsy, I'm part of this group, or I have sleep apnea, I'm part of this group. And guess what? If you have this too, they're doing this clinical trial on this particular medication. It's 6 weeks long. It goes like this, contact me for more details. So, and of course, these days, thanks to social media, a lot of, things can easily circulate among people with, similar experiences. So I think that's it's things like this, again, that sound kind of small, but really make a big difference overall.
Actually, I don't see them as small at all. I mean, social media, we've seen its impact in so many different realms and so many different worlds, political and activism, and, medicine should be no different. And I think that it is almost a bit of an equalizer, in the sense that if you live wherever, if you live in a big city or if you live in a small town and you have access to the internet, which the vast majority of people do in some capacity, I think that social media is one of the best ways to, not everybody, for example, is going to pick up the newspaper or, whatever, read a book, but a lot of people across different age groups are scrolling through social media and can then see this and relate to. And especially if she's talking about a personal experience, if she's talking from a place of, I have this, I'm not talking at you, I'm talking to you and with you. And so I think that that's really, really valuable. So I would say, on a final note, just kind of looking forward, what do you see as the most promising things that are happening right now in the field, in the sleep medicine field, to target narcolepsy specifically, to make it more accessible in terms of awareness and in terms of diagnosis, and then subsequently in terms of treatment for a much larger segment of the population, at least here in the US for now?
Yeah. Well, to address the first part of your question, I think one thing that's, in terms of clinical research and sort of where I sit as a sleep provider in all of this, or a sleep medicine provider.
Yeah, we wish you were a sleep
I'd
provider.
like to provide sleep to everybody, but with that said, what I'm very happy about is this kind of overall shift in the direction of how we approach the treatment of these patients, because a lot of the majority of treatments that are being studied for narcolepsy now are non-stimulant treatments, whereas traditionally that was, as you said, really our go-to. It was our first drug of choice, was using these medications. So the fact that we're moving away from that, not that those medications are bad, stimulants are very helpful to a lot of people. Of course, they're not perfect, but for many people, that's really helpful for them. But for many people who have those hallucinations, for many people who have that paralysis, there's these kind of distressing nighttime phenomena and disruption to their nighttime sleep, which stimulants...
Or type 2, which will have like cataplexy and things like that. Stimulants not going to...
Correct, type 1, yes.
Or
exactly.
I'm sorry, type 1.
No, I know what you meant. So with cataplexy, absolutely. Sleepiness is the main problem, but it's not the only problem. And the fact that now the medications that we're looking at and studying and are getting approved more recently are medications that are focused on addressing all of the syndrome as
More
opposed to just... Correct. So that's something that's very positive, I think, which is good. Of course, next thing you know, next week a new stimulant is going to come out. But no, with that said, hey, this is the best one. No, but with that said, apart from that, I would say that going back to what we were just talking about in terms of social media and outreach, and these people who are sharing their own experiences as part of these large organizations now, getting together and making friends with people who have narcolepsy or sleep disorders in other countries, and kind of creating awareness really from a grassroots kind of origin, I think that really is the future of educating the community and even our clinicians, because not to say anything negative about any of our clinicians, but a lot of our clinicians are not thinking of narcolepsy when they evaluate people for symptoms like fatigue, sleepiness, disrupted sleep, unrefreshing sleep. So just kind of getting the word out there, not only to hear what patients have to say, but the people who are evaluating these patients, they need to be reminded of how to look out for these people too.
Dr. Kashani, thank you so much.
Thank you for having me.
It's been a very enlightening conversation. And, like I said at the beginning of this, I personally want more people to know and to understand it. And as someone who works in media, it disappoints me that the misconceptions that are out there are caused by the representations in media. But I also feel like media could be part of the solution, just like it's kind of part of the problem, whether that be mainstream media or social media or whatever. But I'm hoping, and I am reassured by some of the things you said, that we're at least moving in positive directions in terms of creating awareness, in terms of finding treatments that tackle the problem more holistically and tackle the root of the problem as opposed to just the symptoms. So let's hope, and let's have another conversation maybe in another 5 or 6 years, and hope that there's much more out there and much more awareness. So thank you so much.